Good evening, all. Welcome to our webinar on breakthroughs in early cancer detection and treatment, organized by International Association of Oncology and Bioleagues Worldwide, sponsored by AstraZeneca and OnQuest Laboratory. So let me welcome to you and introduce to you first our delegates for the day. We have been joined here by our chairperson, Dr. Rajan Santosham, who is the cardiothoracic surgeon from Apollo Hospitals, Chennai from India. And our eminent speakers for the day, Dr. Vinay Bhatia, consultant molecular biology from OnQuest Laboratory, Dr. Shoaib Zaidi, the surgical oncologist from Institute of Cancer, Indraprastha Apollo Hospitals from New Delhi, India. Dr. Sandeep Goyale, head of medical oncology from Kokilaben Dhirubhai Ambani Hospital and Research Institute, Mumbai, India. And our panelist for the day, Dr. Sachin Marda, surgical oncologist and robotic surgeon from Yashoda Hospitals, Sumajiguda from Hyderabad, India. Dr. Indu Bansal Agarwal, the director from Narayana Super Speciality Hospital from Gurgaon, India. Dr. Sabita Jivnani, the associate professor, thoracic services at Department of Surgical Oncology from Tata Memorial Hospital, Mumbai, Maharashtra. Dr. Abhinav Gilani, associate consultant, chest medicine from Sir Ganga Ram Hospital from New Delhi, India. Dr. Ashish Singh, medical oncologist from CMC Vellore from India, and Dr. Sunil Jaiswal, the surgical oncologist from Amri Hospital, Bhubaneswar, India. So before we begin, let me introduce to you our organizers and our sponsors for the day. So we all know lung cancer, also known as carcinoma, is considered to be one of the common cancers after breast cancer. Hence, today we are here to spread awareness on how to detect lung cancer at an early stage and how to treat them. And this topic has been brought up by our experts and our sponsors to discuss on this platform. So let me first welcome to you and introduce to you the International Association of Oncology, which is the leading professional association integrating oncologists across domains such as medical oncology, surgical oncology, uro-oncology, and also research scientists, academicians, and life science professionals meant for research and development in the field of oncology. IU has been an organization who has been regularly conducting various conferences, webinars, and related scientific events to increase awareness in the field of oncology. And today, with the support of our eminent delegates, we'll be discussing on the detection and treatment of lung cancer. Let me welcome and introduce to you next Bioleagues Worldwide. Bioleagues Worldwide is a non-for-profit association which prominently promotes research and development in the field of medical science and life science. Bioleagues have brought a revolution in the field of worldwide conferences. Bioleagues Worldwide conferences bring together the professional wizards and leaders who have explored all avenues to reinforce the field of life science and medical science. Bioleagues Worldwide conducts events worldwide which help in enhancing the skill set of the people from diverse industries and forms a common platform for eminent personalities, physicians, doctors, researchers, and academicians and professional business figures, and many more. Bioleagues conferences encourages better comprehension about improvements and progressions over the world through worldwide conferences with the speed of science and technology. And next, I would like to welcome and introduce to you our sponsors for the day. AstraZeneca, which is a global science-led biopharmaceutical company, and the innovative medicines by AstraZeneca are used by millions of patients worldwide. AstraZeneca is the world's largest pharmaceutical company, manufacturing products for major diseases in areas including oncology, cardiovascular, gastrointestinal, infection, neuroscience, respiratory, and inflammation. It is perhaps best known for its involvement in developing the Oxford AstraZeneca COVID-19 vaccine. AstraZeneca is leading a revolution in oncology to redefine cancer care. Lung cancer is at the forefront of AstraZeneca's research and development focus. Next, I would like to welcome and introduce to you OncoQuest Laboratories Limited, which has been a 2-decade legacy of trust and accuracy in pathology testing. A favorite among clinicians, specialty hospitals, and other path labs. OncoQuest is known for second opinion and final diagnosis using most advanced technology and skills, and for its excellence in molecular and clinical diagnosis. OnQuest has a highly skilled and globally reputed team of qualified doctors with combined experience of 600 plus years. Its logistic capabilities and pan-Asia geographical spread makes OnQuest an ideal associate for all clinical activities. So next, I would like to welcome our chairperson, who will be giving us a welcome note to all our delegates who have joined us, and also to all the participants who have joined us today evening. So let me introduce to you and welcome Dr. Rajan Santosham, the chairman of the Santosham Chest Hospital. Sir has done his started his education from Madras Medical College as a student, and retired in 2005 as head of the Department of Cardiovascular and Thoracic Surgery at Government General Hospital. And Dr. Rajan Santosham, who specialized in thoracic surgery, fed his interest in the field of surgery despite his exacting schedule at the Government Hospital. Now he is working as the chairman of the Santosham Chest Hospital, and he's also the professional member of 17 professional bodies across the globe. Among his achievements is the Lifetime Achievement Award from the Indian Association of Oncology, and admission as a fellow to the European Society of Thoracic Surgeons and to the Royal College of Surgeons of Edinburgh. He has trained many surgeons and pulmonologists and conducted workshops in bronchoscopy. Good evening, sir. It's an absolute honor to have you today evening. Thank you for joining us.
Yeah. Thank you very much. You didn't tell about yourself. Where are you from?
My name is Jazila Mustafa, and I represent Bioleagues worldwide.
Okay, I've been given 5 minutes. I'll try to finish whatever I have to say. See, I am, as she already told you, I'm from Chairman Santosham Chest Hospital and thoracic surgeon from Apollo Hospital. And I also teach thoracic surgery as an honorary consultant in Cancer Institute ADAURA, which is one of the primary cancer specialty hospitals. I've had a long journey. My affinity to thoracic surgery comes from my late father, Dr. Madaram Santosham, who was a thoracic specialist, TB specialist. And when I qualified for MCH in thoracic surgery in 1977, everybody wanted to take cardiac surgery because it was glamorous, a lot of money, and it was very interesting for most. But I stuck to thoracic surgery, and I'm happy I stuck to it, because now cardiac surgery slowly is taking a backstage because of the interventional cardiology. One of the things that I wanted to stress was the smoking. Smoking was very prevalent when I was young. And unless you smoked, you were not considered as a man. For example, my father used to be a chain smoker. And now we know the problems of smoking. A lot of advances have occurred. Earlier, during my younger days, most lung lesions in our country were treated as tuberculosis. And now what has happened, a lot of changes have happened. There is a lot of awareness in the general physicians and pulmonologists, and we are seeing more and more early lung cancers. And after this COVID, a lot of people who have taken CT scan for COVID have landed up with early lung cancer. So the challenges have changed, and the treatment have changed. The original idea of debulking these tumors have completely gone. Now we have very clear idea which patient you can put a knife on, which patient you must hand over for chemotherapy and radiotherapy. Like advances in radiology, bronchoscopy, and radiotherapy has come a long way. When I started practice, if I saw a bronchogenic carcinoma patient in my outpatient, I was never able, I was sure I'm not going to see him after 6 months. Now, I know patients who have had advanced bronchogenic carcinoma treated with chemotherapy, especially oral chemotherapy, and living for 8-9 years, which is a new revelation to me, new revelation. And I have been associated with the Indian Association of Cardiothoracic Surgery, and I was a past president and secretary, and I was given a Lifetime Achievement Award. My greatest joy is a couple of years back, we started the Indian Society of Thoracic Surgeons in India, like something similar to the European Society of Thoracic Surgery, where we have people of different surgical specialties, like surgical oncologists. And this has been a new revelation, and we have also been recognized by the European Society, and we have been very happy, very happy about that. Lot of young budding surgeons now want to become, because of the advances in VADS, uniportal VADS, diagnosis of early bronchogenic carcinoma, they want to become thoracic surgeons. In fact, in our country, we have also started the DNB program in thoracic surgery, thanks to my friend, Dr. Babitosh Biswas. I'm very happy for having been invited to this nice audience. And I am telling you, earlier, I was the first guy to qualify for ECFMG, and I had a chance to go to the US. Today, I'm very happy that I stayed behind in my country. We are not lacking in anything. In our country now, so much of progress has occurred in my lifetime. And just before this, I had a Zoom meeting with my own classmates, MBBS classmates just now, and I'm so happy and grateful to my country. Thank you very much. I think just 5 minutes is right. Thank you.
Thank you so much, Dr. Rajan Santosham, for your kind words and for sparing your valuable time with us. So without any delay, I would like to move on to our speakers for the day. So firstly, I would like to welcome Dr. Shoaib Zaidi, who is a surgical oncologist from Institute of Cancer Indraprastha Hospital, Apollo Hospitals from New Delhi, India. He has been serving our country for the past 17 years. And Dr. Zaidi is well-trained in diagnosing and treating head and neck cancers and breast cancers. Dr. Zaidi is popularly known as the specialist who performed the first robotic esophagectomy and lobectomy for esophageal and lung cancer in Delhi in 2011. Dr. Zaidi has a history of providing 100% relief to cancer patients. Welcome, Dr. Zaidi, to our webinar.
Thank you for the kind words. Without delay, I would start my presentation. I have been asked to present it for 20 minutes. So hopefully if I finish early, I should be able to show you a few clips of my modified uniportal VATS left upper lobectomy. So are you able to see the presentation?
Not yet, sir. You can start sharing your screen. Yeah.
Just give me a minute. There's some problem here. Are you able to see now?
Not yet, sir.
Just a moment, just a moment. Some problem with the privacy settings. Let me just do it.
So you can just click on the share screen. I have enabled this share screen option.
Yeah, I am doing it, but I think maybe the next person can present and I do the settings on my computer.
Yeah, sure, sir.
Okay.
Okay, next I would like to welcome our next speaker who will be presenting. That's Dr. Vinay Bhatia from the Consultant Molecular Biology from OncoQuest Laboratory, New Delhi, India. And she has been serving for more than 17 years. And she had worked as a senior research officer at Super Religare Laboratories Limited from 2006 to 2011. And she has done her doctorate in biochemistry at CCS HAU Hisar. Dr. Vinay Bhatia, would you mind presenting?
Yeah, sure.
Yeah, thank you so much.
Is my screen is visible to all?
Yes, ma'am, it's visible.
Yeah. Good evening, everyone. Thank you so much for the kind words. Myself, Dr. Vinay Bhatia, welcome you all for this webinar on the topic, which is detection of therapeutically targetable EGFR mutations in early stage lung cancer. As we all know that biomarker testing in non-small cell lung adenocarcinoma is need of the hour. Various randomized studies have compared first-line EGFR TKI with standard chemotherapy, and these studies have demonstrated the superiority of EGFR TKI over chemotherapy in terms of response, progression-free survival, and quality of life, resulting in the approval of these agents for the treatment of EGFR mutant lung carcinoma. Lung cancer can be subdivided into two major histological subtypes: non-small cell lung cancer, which contributes to 85% of the total disease, and small cell lung cancer, which contributes to 15%. Non-small cell lung cancer is further subdivided into squamous cell carcinoma, adenocarcinoma, and large cell carcinoma. Since the discovery of EGFR mutant lung cancer, a number of driver mutations have been identified in lung adenocarcinoma, like mutation in ALK, HER2, BRAF, PIK3CA, AKT1, NRAS, and so on. Many of these mutations are clustered around the domain of gene of interest, TK domain, a tyrosine kinase domain of the gene of interest, and result in constitutive activation of mutant proteins and downstream signaling. EGFR mutations are among the most common identified mutations in patients with adenocarcinoma of the lung, along with KRAS. What is EGFR? EGFR is epidermal growth factor receptor, which belongs to ERB family of closely related receptor kinases. It has an extracellular ligand binding domain and a transmembrane portion and the intracellular tyrosine kinase and regulatory domain. Upon binding with the specific ligand, which is epidermal growth factor, the normal functioning of EGFR undergoes conformational change and phosphorylation of the intercellular domain occurs, leading to downstream signaling, which is normal cell growth, proliferation, and differentiation, basically through the inhibition of apoptosis. But in case of if there is a mutation in EGFR tyrosine kinase domain, it will lead to constitutive activation of this particular receptor, leading to aggressive tumor growth and progression via proliferation, invasion, angiogenesis, and metastasis. Mutation in EGFR are considered to be the standard predictive biomarkers being indicative of treatment response, and this constitutes the basis of alternative target therapies, that is EGFR tyrosine kinase inhibitors. EGFR is constituted of 28 exons and located on the short arm of chromosome number 7, which encodes 170 kilodalton transmembrane glycoprotein with important function of cell signal transduction. Most common mutation include mutation in exon 19 and exon 21. In exon 19, it is deletion exon 19, which contributes to almost 45% of the mutations which are being observed in EGFR. Similarly, in exon 21, there is a most common mutation which is being observed at position 858 L2R, which also contributes altogether 85% of the EGFR mutation of lung cancer cells. This is overall a representation of the location of the most frequent EGFR mutations in non-small cell lung cancer and their relationship to the resistance and sensitivity in the treatment with TKI. So most of the mutations are clustered in exon 18, 19, 20, and 21. The green one represents the mutation which are responsible for sensitivity to TKI, while the red one represents the mutation which are responsible for imparting resistance against TKI. If we look at the geographical distribution of EGFR mutation frequencies in patients with non-small cell lung cancer of adenocarcinoma histology, the maximum percentage was observed in Vietnam, which is 64%, followed by Philippines and Taiwan and Japan, which is in the range of 40 to 50% of frequency. In US, it is around 15 to 25%, while if we talk about India, almost 30% of the patients with non-small cell lung cancers are presented with EGFR mutations. Hence, all the non-small cell lung cancer patients should undergo EGFR mutation testing. Now, coming to the samples which are to be used for EGFR testing. The most preferred sample type for all genetic mutation testing in advanced non-small cell lung cancer is tumor biopsy sample, which is obtained through surgery or bronchoscopy. Cytology samples are also being used, obtained through bronchoscopy, thoracentesis, and needle aspiration. However, sample quality and tumor cell content may be lower than the biopsy samples. If there is unavailability of the sample from biopsy or cytology through invasive method, this this EGFR mutation testing can be done with a new technology which is called liquid biopsy. So this is a new source of cancer biomarker. Basically, liquid biopsy, we require samples as a blood. Basically, we work on plasma on this. Then urine, sputum, and pleural effusion samples can also be used, which are basically used for response monitoring along with tumor recurrence detection and determination of residual disease after full tumor resection. However, the cancer cell content of cytology sample and these samples are much lower than the biopsy sample. What are the different methods which are used to collect tumor samples for diagnostics and biomarker testing? There are different diagnostic modalities are available, which is like bronchoscopy, we get endobronchial biopsy, transbronchial biopsy, brushing cytology, washing cytology, and FNA cytology, with a diagnostic yield of 58% to 94%, depending on if a lesion is visible and if biopsy, brushing, and washings are combined for diagnostic test. Similarly, through surgical diagnostic modality, we get tissue biopsy with the diagnostic yield of 80 to 97%. Image guided, which is basically a transthoracic needle aspiration, we get sample CNB, FNA cytology, fluid cytology, bone biopsy with the diagnostic yield of 57% to 95%. In case of bone biopsies, the adequacy for biomarker testing is variable because of the decalcifying agents. Tissue is the gold standard. However, quality of the tissue and quantity of tumor content is very crucial for successful biomarker testing. We should be having enough tumor content in the tissue sample to be tested for biomarker to get an appropriate result of finding. So what are the pre-analytical processes for EGFR testing? As we have already, we already know that tissue sample are the sample of choice for EGFR testing, but tissue samples are very fragile and undergo degradation immediately after the removal from the body. So for that particular reason, these sample needs to be either they should be processed immediately or should be fixed immediately to preserve tumor characteristics. And that fixation of tissue sample is done in 10% and formalin solution, which is most common and preferred method of fixation, which allows for histological and molecular analysis. However, for cytology sample, 70% ethanol fixation is done, which is often used for cytology, but not these cytology samples are not suitable for most histological analysis. Duration of fixation is really important, which impact diagnostic test yield. As we know that 10% formalin fixation leads to chemical cross links to proteins, RNAs, and DNAs. And this fixation is not complete until formalin has fully penetrated the tissue and the individual chemical reactions have completed. So basically, duration of fixation must be long enough to allow for both complete penetration and complete chemical fixation, which is actually recommended 6 to 12 hours for small biopsy samples and 8 to 72 hours for larger biopsy surgical samples. So what happens if there is underfixation? Molecules in underfixed tissue will begin to degrade, compromising the sample quality, and eventually will get false negative results. And what happens if there is overfixation? Extended fixation can cause DNA mutation, damage, and breakage, which will hinder this particular sample for protein detection in IHC analysis. So in short, the proportion of sample that is tumor should be more than 50%, equal to 50% or more than 50% ideally to be processed for biomarker testing, and there should be more than 200% tumor cells present in the sample which is being used for biomarker testing. Tissue biopsy sample preparation is an important factor to obtain the best molecular testing results. So there are certain considerations for tissue sample collection and preparation for EGFR mutation testing, like when a surgical section or open biopsy tissue is collected, it should be immediately placed in neutral 10% neutral buffer formalin, which after the particular duration of time as recommended, it should be embedded into paraffin block. Then block is sectioned with microtom. These sections are additional sections are being cut for DNA extraction and purification. Staining is done for pathological review. Basically, the pathologist will let us know what was the tumor content looking at these slides. Fixation time for 6 to 12 hours for small biopsy sample and 8 to 18 hours for larger surgical samples give the best result for molecular testing. What are the different platforms used for EGFR testing? There are different testing platforms with different sensitivity and limit of detection. So what is limit of detection? Limit of detection is the smallest amount of mutant DNA or the clonal population of mutant DNA that can be routinely detected in a background of normal DNA. As we know that when we collect a sample, a biopsy sample, it is heterogeneous in nature. It will be having tumor cell mixed with the normal cell. So we need to pick up a particular test of a platform with a better sensitivity in case the tumor content is not as recommended, which is 50%. So there are different platforms available with different sensitivity, which will give test those critical samples when the tumor content is and the sample is low. There can be different reasons for false negative results, like if the tumor content is not there in the sample at all, or DNA is fragmented because of the overfixation. As we know that overfixation in formalin can lead to DNA fragmentation. And if the DNA which is extracted from those samples is in fragmented form, then it would be difficult to get the appropriate biomarker testing result from those samples. There are different techniques or technologies available, like sequencing, ARMS, or NGS, which have different specification. Like for sequencing, the PCR product size is more than 500 to 750 base pair size. But in case of ARMS PCR, which is RT-PCR, we have a basically we can pick up a PCR. The PCR product size is less than 200 base pair size. So in a scenario when the DNA is fragmented due to overfixation, and we have got the fragmented DNA, small fragments are there. So this particular technology will take care and will give us the appropriate results. So these kind of testing modalities are available, which are more sensitive with the better limit of detection, which can be used in these scenarios. So coming to the different platforms for EGFR mutation detection, we have different testing modalities available as far as the molecular diagnostics is concerned: RT-PCR, digital PCR, and next-gen sequencing. For RT-PCR, 3 different FDA-approved platforms are available. One from Roche, the other is from QIAGEN, and the third one is from ADAURA. Roche can pick up 42 mutation in exon 18, 19, 20, and 21 of EGFR gene, which are the most relevant clinically relevant mutations. Similarly, by QIAGEN, we can pick up 29 mutations, all clinically important mutations in the 18, 19, 20, and 21 exon of EGFR gene. Similarly, MOIDX can also pick up 29 mutation in these 4 exons of EGFR. Coming to the Bio-Rad ddPCR, this Bio-Rad ddPCR is a digital droplet PCR, which can pick up all important clinically relevant mutations with resistant, which will provide us the resistance status or the susceptibility status of major mutation, which are in exon 19 and 21, deletion mutation in exon 19 and 21, which is L858R. Similarly, the resistance mutation at position 719 can also be picked up by Bio-Rad ddPCR. Coming to the high-end technology, which is next generation sequencing available in 2 different formats. One is on MySeq, which is from Illumina. The other one is Iron Torrent, which is from Thermo. This will give a broad mutation coverage, which requires specific primer and probe designing. Limit of detection for RT-PCR is 2 to 3% for formalin fixed paraffin embedded tissue and 100 copies per ml for plasma for the particular mutation, resistant mutation for TKI. QIAGEN have a limit of detection as 1%. Similarly, ADAURA also have 1% for FFPET and 0.2% for plasma super ARMS PCR. Coming to digital PCR, which is from Bio-Rad, the limit of detection is as low as 0.2%. And next-gen sequencing is the high-end technology with the limit of detection in the range 0.1 to 0.5%. Now coming to the advantages and disadvantages of these different technologies and platforms. RT-PCR platforms from Roche, QIAGEN, and AmoiDX are the FDA-approved method for mutational analysis, but these can give us the information about only certain known mutations, although will not give us the absolute quantification. While Bio-Rad ddPCR can give us the absolute quantification with high sensitivity and specificity, but again, this will detect only non-targeted mutations like RT-PCR. But the added advantage of next generation sequencing is it is with high throughput, which will pick up maximum mutation, more number of mutations, array of spectrum of mutations with input as less as 1 nanogram genomic DNA. The disadvantage of next-gen sequencing is that the turnaround time is going to be very high, and with the cost is also very high as compared to RT-PCR and digital PCR. So what is turnaround time? So turnaround time is the time between requesting the mutation test and reporting the test results back to the treating physician or oncologist. It should be as short as possible to ensure treatment decisions should be made, so that treatment decision should be made quickly. Ideally, less than 7 days working days between request for test and receipt of results. But as we know that there are multitudes of steps which are involved in mutation testing, means small delays at each step can cause a significant time lag in reporting the final results. So in short, tissue-based EGFR mutation detection on RT-PCR with a shorter platform is the FDA recommended testing method, which is recommended for finding out the status of all clinically important mutations in EGFR. What are the NCCN guidelines on EGFR mutation testing in early stage cancer? NCCN says that EGFR mutation to be performed on diagnostic biopsy or post-surgical resection sample to ensure the EGFR mutation results are available for adjuvant treatment decisions for patients with stage 1B to 3A non-small cell lung cancer. Also in patients who have received previous adjuvant chemotherapy or are ineligible to receive platinum-based chemotherapy, EGFR mutation testing is recommended. How to do the result interpretation? This is the result format which we generally get, either positive or negative for one particular mutation. If patient is positive, it means it is mutation is detected in this particular case, while if it is given negative, means that particular mutation is not detected. When an EGFR mutation is detected, a specific genotype is reported. Although most of the mutations will predict a favorable response to anti-EGFR therapies, there are rare mutations which are associated with lack of clinical response to anti-EGFR, like at position 790 from T to M. These mutations are desensitizing mutations. Takeaways, take-home messages, as per NCCN guidelines, all non-small cell lung cancer adenocarcinoma patients need to go for EGFR mutation testing to take treatment decision. Tumor tissue is the gold standard for successful EGFR mutation testing, and RT-PCR platform is recommended by FDA for tissue-based EGFR mutation detection. Thank you so much.
Thank you, Dr. Vinay Bhatia, for your amazing, informative talk that you have given to us on EGFR mutation test in early lung cancer. Thank you so much, ma'am. So next, I would like to welcome Dr. Shoaib Zaidi, if he would be able to present now. Dr. Zaidi? Yes, thank you so much, sir. So Dr. Zaidi will be discussing on the surgical case study on incidental solitary nodule. Sir, can you unmute yourself? So you can go to the Zoom and you can unmute your audio. Dr. Zaidi, can you hear us? Okay, without any delay, we'll move on to our next speaker who has joined us here. Next, I would like to welcome Dr. Sandeep Goyale, who is the head of Medical Oncology Department at Kokila Dhirubhai Ambani Hospital and Research Institute from Mumbai, India. He'll be discussing on the new updates in the management of early lung cancer. Welcome, Dr. Sandeep Goyale. So can you hear us? So you can unmute from your side.
Hello.
Yes,
Can you hear me?
Yes, sir. Absolutely.
Okay.
Yeah.
Actually, the host was not allowing us to unmute. Now it has allowed to unmute.
Okay, okay.
Yes. So thank you very much for the invitation. I'm just going to share my slides, please.
Yeah, sure.
Can you see the slides?
Yes, sir.
Okay. So thank you very much, AstraZeneca, for giving me this opportunity. I'm Dr. Sandeep Goyal, Head Medical Oncology, Kokilaben, Dhirubhai Ambani Hospital, Mumbai. And I'm going to give a brief overview of new updates in management of resected early lung cancer, EGFR mutation positive. So we all know that lung cancer is the leading cause of cancer death and accounts for more than 1.7 million of deaths annually. Non-small cell lung cancer accounts for 85% of all lung cancer cases, and about 1/3 of these cases, that is 30%, would be early stage or resectable disease at diagnosis. Right. Surgery is the main primary treatment for these patients, and adjuvant cisplatin-based chemotherapy is now recommended for patients with stage 2A, stage 3A non-small cell lung cancer post-surgery, and select patients with stage 1B disease. And data from randomized trials have shown that there's a 5-year OS benefit as well as a DFS benefit with adjuvant chemotherapy. However, in spite of adequate surgery and adjuvant chemotherapy, the overall disease recurrence or death remains high across stages. So you can see in stage 1B is about 45%, stage 2 about 62%, and stage 3 about 76%. So there's a really unmet need in this category of patients to improve their survival. We routinely test EGFR mutation status for all cancer patients who are non-small cell lung cancer stage 4. And now we have started to test for early stage cancers as well. But based on the limited number of studies, the prevalence of EGFR mutations across different disease stages in non-small cell lung cancer is almost similar. So in the advanced stages, you have in the stage 4, you've got about 30 to 50% of patients in various studies have shown to be EGFR mutation positive. In the early stages also, you've got about similar number of patients who are EGFR mutation positive. And now the trend is that any patient of non-small cell lung cancer, whether it's early stage or late stage, should have an EGFR mutation result with them, because there's a definite benefit of using an EGFR TKI even in the early setting. So this study, the ADAURA study, is what we're going to discuss now, is the use of Osimertinib as adjuvant therapy in patients with stage 1B, stage 2, stage 3A, EGFR mutation positive, non-small cell lung cancer after complete tumor resection. So this was a phase 3 double-blind study. patients more than 18 years, good performance status, confirmed primary non-squamous non-small cell lung cancer, exon 19 deletion and L858R mutation positive, and complete resection with negative margins. These were the inclusion criteria. They could have received adjuvant chemotherapy or they would not have received adjuvant chemotherapy. Both these patients were included. If they had adjuvant chemotherapy, then the randomization was within 10 weeks, and without adjuvant chemotherapy within 10 weeks, and with adjuvant chemotherapy 26 weeks between surgery and randomization. They were stratified by stage, EGFR mutation status, and race, and 682 patients were randomized 1:1 to receive either osimertinib 80 milligrams once a day or placebo once a day. The planned treatment duration was for 3 years, and the treatment continues till disease recurrence, treatment completed, or discontinuation criteria met. The primary endpoint was disease-free survival by investigator assessment in stage 2 and 3A patients. And the secondary endpoints were DFS in the overall population, DFS at 2, 3, 4, and 5 years, overall survival, safety, and health-related quality of life. The study was unblinded early due to efficacy, and therefore we report only the unplanned interim analysis in this presentation. And the patients were followed at least 1 year who were reported here. So these were the inclusion-exclusion criteria. We have discussed that. The baseline characteristics were similar, in terms of age, sex, smoking status, race, the performance status. 96% of patients were adenocarcinoma. 55% of patients had exon 19 deletion positive, and 45% of patients had L858R mutation positive in both the arms. 60% of patients had received chemotherapy, adjuvant chemotherapy, and 40% did not receive any adjuvant chemotherapy. And look at the data, the DFS, the primary endpoint. So osimertinib improved DFS versus placebo in resected EGFR mutation non-small cell lung cancer. If you look at the left side, the stage 2 and stage 3A, which was the primary endpoint, the primary population, the median DFS has still not reached in the osimertinib arm. It is 19.6 months in the placebo arm. And look at the hazard ratio, 0.17, p-value less than 0.001. So this means that there was an 83% reduction in the risk of disease recurrence or death with osimertinib as compared to placebo. If you look at the overall population, which included patients with stage 1B as well, again, there was a good hazard ratio, 0.2, p-value significant less than 0.001. That means 80% reduction in the risk of death or recurrence with osimertinib. So these are impressive results with the use of osimertinib in these patients. If you look at the 2-year DFS, it was consistent for the osimertinib arm across all the disease stages. So stage 1B, stage 2, stage 3A, it was around 88 to 91%, such high 2-year DFS percentage. The DFS percentage with the placebo obviously reduced as the stage progressed, and therefore the hazard ratio for DFS improved for osimertinib as the stage progressed. If you look at the subgroup analysis of disease recurrence or death according to investigator assessment, all subgroup analysis favored the osimertinib arm in terms of sex, age, smoking history, race. Look at the stage. Although stage 1B was slightly less favorable, but stage 2 and stage 3A were quite good DFS benefit. Both exon 19 deletion and L858R mutation positive patients had benefit with osimertinib, and patients, whether they received adjuvant chemotherapy or whether they did not receive adjuvant chemotherapy, both the groups favored the osimertinib arm. This is the early snapshot of the overall survival in patients with stage 2 and stage 3 disease, the primary population. And you see, both with placebo as well as with osimertinib, the median OS has still not reached. If you look at the 2-year OS in percentage, all the patients on osimertinib have survived 2 years, and 93% of patients on placebo have survived 2 years. Hazard ratio 0.4. This has still need to be mature, but this is the early snapshot. Now coming on to, these are the 5 trials which have evaluated the role of adjuvant EGFR TKI in the EGFR mutation positive non-small cell lung cancer. And all of them, the SELECT, RADIANT, EVEN, adjuvant CTONG trials, all of them have shown there is a DFS improvement, but no overall survival improvement. The other thing which we need to understand and grasp is the type of recurrence, which is a key consideration in resected non-small cell lung cancer, because the local versus distant recurrence has an impact on the patient outcomes. Local regional recurrence associated with a longer post-recurrence survival than distant recurrence. CNS is a common set of recurrence, distant recurrence in patients with EGFR mutation non-small cell lung cancer. If you look at the RADIANT study, 37% of recurrences in patients with EGFR mutation non-small cell lung cancer had CNS involvement with erlotinib. Now, osimertinib has the advantage of having a significant exposure in the blood, in the brain, and we have seen that in the advanced setting. Now, whether that translates into an early setting, this is what we will see in the next few slides. So, type of disease recurrence. 11% of patients in the osimertinib arm had DFS events, either disease recurrence or death, versus 46% of patients in the placebo arm. So, if you look at the recurrence type, among the 11% of patients in the osimertinib arm, 62% of patients had local or regional recurrence only. Only 38% of patients had distant recurrence. Now look at the placebo. 46% of patients had recurrence. Out of that, it's a reverse. 61% had distant recurrence and 39% had local recurrence. So this is the type of recurrence with osimertinib as compared to placebo. And then the sites of disease recurrence. So if you look at the 11% who had disease recurrence with osimertinib, lung recurrence was 6%, lymph node 3%, CNS only 1%. That is, only 6 patients among all the patients had CNS recurrence, as compared to placebo, where 10% patients had CNS recurrence. These are the CNS recurrence in 1% in osimertinib and 10% in placebo, and death also 1% osimertinib with CNS events and 2% with placebo. And if you look at the CNS DFS in the overall population, with osimertinib is still not reached, with placebo 48 months, hazard ratio 0.18, p-value less than 0.001. So again, with regards to the CNS recurrence, osimertinib was better than placebo. Coming on to the safety summary, we have to talk about the second side of the coin, same coin. We have talked about the benefits, we have talked about side effects now. So you look at the bottom rows, possibly causal related side effects. So not much, grade 3, 10% with osimertinib and placebo 3%. No ANEs leading to death in either arms, 3 serious ANEs, serious adverse events, 3% with osimertinib and 1% with placebo. And what are the kind of adverse events do you see with osimertinibs? Diarrhea, obviously, paronychia, dry skin, pruritus, cough. These are the adverse events which we see. And I think we can manage them quite well. Grade 1 to interstitial lung disease was reported in only 3% of patients, and QTc prolongation was in 7% of patients osimertinib arm. So can be managed easily, and that's what the experience we have in the metastatic setting when we give osimertinib. Coming on to whether osimertinib benefits adjuvant therapy, post-op chemotherapy use and outcomes of the ADAURA study, the subgroup analysis. So 60% of patients had received adjuvant chemotherapy and 40% did not receive adjuvant chemotherapy in both the groups. And you can see the difference. The DFS in patients with and without adjuvant chemotherapy. Whether you give adjuvant chemotherapy, whether you do not give adjuvant chemotherapy, the DFS was, the 2-year DFS was 89% with osimertinib in both the subgroups. So it did not make a difference whether the patient received adjuvant chemotherapy or not. And quite a few patients after surgery are not able to receive adjuvant chemotherapy because they are not fit enough to receive adjuvant chemotherapy. So in all those patients also, adjuvant osimertinib is of benefit. This is the stage-wise. Stage 1B, again, there was a difference with osimertinib. Stage 2 and stage 3A, again, the higher the stage, more the difference between placebo and osimertinib with regards to DFS. Coming on to the patient-reported outcomes from ADAURA, osimertinib adjuvant therapy. And if you look at the health-rated quality of life method, these were the data collected. And they showed that during the disease-free period, majority of patients did not experience a clinically meaningful deterioration either in the physical component or the mental component of the health-rated quality of life. So it was very well tolerated. Patients had no problems in accepting the drug, and the side effects were easily managed. So in summary, adjuvant osimertinib is the first targeted agent in global trial to show a statistically significant and clinically meaningful improvement in DFS in patients with stage 1B, stage 2, and stage 3A EGFR mutation non-small cell lung cancer after surgery and plus minus adjuvant chemotherapy. There was a 80% reduction in the risk of disease recurrence or death with osimertinib, hazard ratio 0.20. 2-year DFS rates with osimertinib was 89% as compared to 52% with placebo. And there was a clinically meaningful improvement even in the serious DFS compared with placebo. The safety profile was consistent with previous trials of osimertinib in the adjuvant in the metastatic setting, right? A clinically meaningful DFS benefit with osimertinib was observed in patients with or without adjuvant chemotherapy, regardless of the disease state, whether it's early stage, stage 1B, or stage 2, stage 3A. Higher disease recurrence rates were observed on patients in placebo arm who received adjuvant chemotherapy. And that could be a prognostic factor as well. And overall, the health-related quality of life was maintained with adjuvant osimertinib. So in summary, in conclusion, adjuvant osimertinib provides a highly effective, practice-changing treatment for patients with stage 1B, 2, 3A EGFR mutation non-small cell lung cancer after complete tumor resection. And that is what has been accepted now in all the guidelines. So if we have a patient who has been resected and has received adjuvant chemotherapy or not, if EGFR mutation positive, we put the patient on adjuvant osimertinib. Thank you very much.
Thank you so much, Dr. Sandeep Goyale, for the amazing talk that you have given to us. And thank you so much for sparing your valuable time with us today and enlightening us with a lot of knowledge. So thank you so much. And next, without any delay, I would like to welcome Dr. Shoaib Zaidi.
Yes, good evening. My apologies for the technical snags, both at my computer at the host end also. Can you see my screen?
Not yet, sir.
Not yet, okay.
Yes, sir. Now we can see your screen.
Basically, in next 20 minutes, I will be discussing about solitary pulmonary nodules, how to diagnose and what are the various characteristics and the line of management. And if time permits, if I finish early, then I will show a few minutes of a modified uniportal VATS left upper lobectomy. Now, by definition, it is a well marginated rounded opacity less than equal to 3 centimeter in diameter, and it is completely well marginated, surrounded by lung parenchyma. It does not touch hilum or mediastinum and not associated with adenopathy, atelectasis or pleural effusion. Lesions which are larger than 3 centimeters are considered masses and are treated as malignancies until proved otherwise. Now, there are various etiological factors. All of us know which could be bronchial carcinoma, metastasis, other malignant lung lesions, granulomas, lung abscesses, certain benign tumors, and some benign cysts. Now, the approach to the diagnosis of solitary pulmonary nodule is based on the history and the physical examination, chest radiographs, CT scans, and the comparison with previous imaging if available. X-ray chest, sputum examination, contrast CT or the HRCT of the chest, a PET scan whenever applicable. If required, bronchoscopy and biopsy by FNA, TBNA or transthoracic needle aspiration or VATS, and very rarely open biopsy is required. Now, there are certain quantitative risk models which are not more accurate compared to a physician's and clinician's suspected risk index of suspicion. The most commonly used model is Mayo Clinic model, which comprises of 6 parameters. Other models are Veterans Cooperative models, Brock University model. Now, this is a patient 20 years old patient who presented with history of no history. It was an incidental nodule. He was getting admitted to a medical college. Then he was found to have this lesion on chest radiograph, and he had a CT scan which showed a lesion with subtle speculations. Non-smoker, FNA was done, which was suggestive of spindle cell lesion, and this was resected, and it turned out to be an inflammatory myofibroblastic tumor. Another lady, 24-year-old lady, well marginated lesion. This turned out to be an atypical carcinoid on biopsy. Incidentally found, PET CT did not show any mediastinal nodes. Patient underwent uniportal VATS resection. So I will be showing some few minutes of this video. Now coming to classification, solid nodules are those which block the underlying lung, and if they are well marginated like this, they turn out to be benign. A calcified nodule like this is usually as a result of a healed granuloma, or sometimes maybe a calcified intrapulmonary node. Ground glass opacity, you see the axial section of the right lower lobe, a subtle opacity here, and this was followed up for 2 years, and a CT scan done again showed a slight increase in size of this nodule, and this was again followed up. It was not resected, and it remained static subsequently. Now, ground glass opacity which progresses to more solid pattern, as you see in these images. This lesion was detected in 2010. Around 15 months later, the CT was repeated. You can see a small solid pattern here, and again 10 months later you can see the the solid pattern is increasing. It is still subsolid nodule. It was resected and turned out to be minimally invasive adenocarcinoma with predominant lipidic pattern. This is a nodule which looks suspicious. It can be compared to a typically benign nodule with well-defined borders. Such nodules with speculations have higher chances of malignancy. Now, a nodule which is lobulated has intermediate probability of malignancy like this. This lesion turned out to be a atypical carcinoid. Now, a lesion which has fat or internal calcification usually is a hematoma. It can be diagnosed on a CT scan and can be safely followed up if patient is not symptomatic. The size very well correlates with the likelihood of malignancy in a solitary pulmonary nodule. Nodule size is a dominant factor in the management. More than 75% of nodules which are more than 2 centimeters are malignant, and less than 1% of nodules which are less than 5 millimeter are malignant. When we measure the size of the nodule, usually irregular nodules are measured when we can take average of the long and the short axis and round it off to the nearest whole millimeter. Measurements should be taken usually digitally. We should also assess the doubling time of the lesion. Doubling time is assessed based on the volume of the nodule. One doubling time is 26% increase in the diameter. Solid malignant nodules, they have average doubling times of almost 6 months, or it can range from 20 to 400 days. Subsolid malignant nodules, which is partly solid, partly ground glass opacity, they have longer doubling times. The average is around 3 to 3.5 years, and these nodules can be followed up for 5 years before we label them as benign. A typical nodule, atypical carcinoid, in the left upper lobe. Upper lobe nodules are more likely to be malignant than the lower lobe nodule, but it's not, this should not be the only criteria to assess malignancy. Now, usually calcified nodules are benign nodules. The calcification can be diffuse calcification or a central calcification, laminated, or a popcorn calcification. As you can see, this is a healed granuloma with a central calcification, another CT image with a laminated calcification. Both these nodules were followed up and they were benign. Now, the risk should be assessed when a patient of solitary thyroid nodule is under investigations. Patients who are low risk are younger, they are not smokers, The size of the nodule is smaller. The nodule has regular margins, and more likely upper lobe nodules are likely to be more malignant. High risk features: older age, history of smoking, and if there is a history of extrathoracic malignancy within 5 years or after 5 years, the chances of it being malignant, very high. The size increases, the risk of malignancy increases. Speculations also increase the risk of malignancy and the upper lobe location. There are certain risk assessment models. Mayo Clinic model, which is most commonly practiced, it's an online model where we have to add these 3 clinical parameters and 3 imaging parameters: history of smoking, age, extrathoracic cancer within 5 years, 3 imaging predictors: nodule diameter, speculations, and upper lobe predominance. Based on these 6 parameters, a percentage probability is calculated. But this model also, which is the most commonly used model, it is not more accurate than clinical assessment. Clinical signs and symptoms, all of us know the suspicious signs of cancer. Now the aim is to determine which nodules are benign so that we can follow them for the first time, and then no further evaluation or follow-up is required. There are 2 basically studies or guidelines: Fleshner Society guidelines published in 2017, and the lung RADS classification. Now the Fleshner Society guidelines are applicable for patients who are older than 35 years, and they should not be used for patients with already known primary cancers who are at risk of metastasis, patients who are immunocompromised, because these patients can develop a lot of pulmonary nodules because of repeated infections, and patients who are being screened. Now coming to small nodules less than 6 millimeter, the risk of malignancy is very, very small, less than 1%, and nodules which have high risk features or patients who have high risk clinical parameters, they should be followed up. CT scan should be done after 12 months, and all the suspicious parameters should be reassessed. Nodules which are more than 6 millimeter or up to 8 millimeters with the low risk history and the low risk clinical parameters, a follow-up after 6 to 12 months is required with a repeat CT chest. If the nodule remains static, a third CT at 12 to 18 months is optional. Patients who have high risk parameters, high risk clinical features, they are followed up for 6 to 12 months depending upon the morphology. The third CT should be done 1.5 years later. The risk of cancer in these patients is around 0.5 to 2%. Solid nodules which are more than 8 millimeters, irrespective of whether it's low risk or high risk, 3 monthly follow-up is required. A PET CT should be done. A tissue sampling also should be done if the nodule persists. The risk of malignancy in such nodules is around 3%. So tissue diagnosis is important whenever the nodule appears to be suspicious. CT guided biopsy or EBUS, transbronchial needle aspiration, and a surgical resection should be performed if malignant. Nodules which are subsolid, like ground glass nodules less than 6 millimeter, do not require any follow-up, and ground glass nodules more than 6 millimeter, they should be scanned at 6 to 12 months, and if the nodule persists, then the subsequent scanning can be done 3 and 5 years later. Nodules which are partly solid less than 6 millimeter do not require any follow-up. More than 6 millimeter nodules should be scanned at 3 to 6 months, and if they persist, then annually for 5 years with a CT. Patients who have multiple nodules, they should be scanned if they have more than 6 millimeters, they should be scanned at 3 to 6 months, and if stable, CT should be done at 2 or 4 years. Multiple nodules more than 6 centimeters, they should be scanned at again 3 to 6 months interval, and subsequent management would depend upon the index of suspicion. Now coming to lung RADS, it is basically imaging classification with the help of low dose CT scans and the cancer screening examinations. So it standardizes the way we report lung imaging of the lung nodules. A negative scan shows less than 1% of malignancy risk when there are no nodules, or when there are benign features like calcifications. A repeat low dose CT is required 12 months later, and if the nodules is static, then no follow-up is required. Lung RADS 2 is for nodules which are, most of these nodules are benign, more than 99%. Less than 6 millimeter nodules, solid nodules, or new nodules which appear 4 millimeters, which appear during the follow-up period. Partly solid nodules less than 6 millimeter in size, ground glass nodules less than 2 centimeter in size, or ground glass nodules which are more than 20 millimeter and which on follow-up are unchanged. They are also included in the lung RADS 2. A repeat scanning after 12 months is required as part of the lung cancer screening guidelines. Lung RADS 3 lesions also are probably benign lesions with 1 to 2% risk of malignancy. Solid nodules 6 to 8 millimeter size, new nodule 4 to 6 millimeter size. New nodule means patients who are under follow-up. If they develop new lesions which are less than 4 to 6 millimeter, they also can be labeled as lung RADS 3. Partly solid nodules more than 6 millimeter with a solid component of less than 6 millimeter, or a new nodule on follow-up which is less than 6 millimeter in the total diameter, also is lung RADS 3. All ground glass nodules which are more than 2 centimeter are also lung RADS 3. Patients require 6 months follow-up with a low dose CT scan. Suspicious lesions, lung RADS 4A, suspicious, the risk of malignancy in them is 5 to 15%. Solid nodules more than 8 millimeters or less than 1.5 centimeters, or a new nodule on follow-up which is more than 6 millimeter but not more than 8 millimeter. Partly solid nodules more than 6 millimeter in diameter, or a nodule which is 6 to 8 millimeter in size, or a nodule less than 4 millimeter which appears during the course of follow-up. For these patients, initial attempt should be done for biopsy, and if it is benign, they can be followed up with a low dose CT. A PET scan may be considered based on the nodule characteristics and size. Lung RADS 4B, they are also suspicious, more than 15% chance of being malignant. A solid nodule which is 1.5 centimeter in diameter, or a nodule which appears on follow-up more than 8 millimeter size is labeled as lung RADS 4B, or a partly solid nodule more than 8 millimeter, or new or growing nodule on follow-up which is more than 4 millimeter. A chest CT with or without contrast is required, or a PET also can be done. Now 4X lesions are lesions which are having a risk of malignancy more than 15%. These are category 3 and 4 nodules with additional features which increase the risk of suspicion, like speculations, or ground glass nodules which double in size in 1 year. Usually ground glass nodules take 3 to 5 years, very long time to double. And large lymph nodes associated with the primary lesion, they also increase the risk of malignancy. A CT chest or a PET CT should be done, and a tissue sampling should be done. Now solid nodules, the sensitivity of PET or the specificity is more than 90% when the diameter is more than 10 millimeters. Subsolid nodules have sensitivity of 90% and specificity of 71%. False negative, we can get in nodules less than 10 millimeter size, patients with well differentiated cancers, carcinoids or atypical carcinoids, and false positives can be in granulomas, or infections. A typical nodule which was looking suspicious on X-ray, PET was positive, but based on the clinical parameters, it was decided to treat this patient with the antibiotics because it was appearing inflammatory, and on subsequent scan it resolved. Now I would like to share. I would like to show you, if the time permits, few minutes of the uniportal modified VADS for the left upper lobe lesion. A patient, I showed this CT, a lesion which was in the upper lobe, turned out to be a typical carcinoid. 2 centimeter lesion without any nodal involvement on imaging. You can see the left upper lobe, superior pulmonary vein being dissected here. Utility incision was used in the 5th intercostal space, anterior axillary line, and a separate port was made for camera. Please let me know when to stop. When my time is up, I will stop the presentation.
Yes, sir. I mean, once your video presentation is over, we may move on to the panel discussion.
Yeah, I will not show the entire video because the entire video is 30 minutes. So
Okay.
I'll show you a few important steps.
Sure.
As you can see, the superior pulmonary vein being dissected, and now we are dissecting the interlobar fissure. As you can see, the branches of the pulmonary artery to the lower lobe here. The fissure was almost 90% complete. These are the branches of the superior pulmonary vein. We are dissecting with ligature over here, harmonic here. We can use either thoracoscopic instruments or maybe standard open instruments through this utility incision, which was 3 centimeter size. This is the highest branch for the apical segment. For young surgeons, you can see the course of the phrenic nerve here, and this is the vagus, which is coming from the neck here. This is arch of aorta. For orientation, this is the neck side and this is the caudal side. One has to be really patient while dissecting these major.
Doctor, I think you should move fast because I think we are already running late of time.
That's okay. I can
we are
stop.
Supposed to be, I think.
Whenever you say, I can stop it.
Yeah, I think we should go for the panel discussion, which is already it's 8:20. We're supposed to start the panel discussion at 8. Okay. Sorry for telling you, but I think the audience will be more benefited by a panel discussion. Yeah. Thank you.
Thank you, Dr. Shoaib Zaidi, for your amazing presentation. So next we are moving on to our panel discussion. For the panel discussion, we'll be discussing on the management of early lung cancer. And our panelists for the day are Dr. Sabita Jivnani from TMH Mumbai, Dr. Sachin Marda from Yashoda Hospital. Then we have joined here by Dr. Abhinav Gilani, Dr. Vinay Bhatia, Dr. Indu Bansal, and Dr. Ashish Singh.
A very good evening to everyone. I hope you can see my slides.
Yes, ma'am.
I'm very
Yes.
sorry for the delay for starting this panel discussion. I'm sure it's very late for most of our delegates. So without much other ado, we'll just start off. And thanks to all the previous speakers, they have already, given us a view of the guidelines of the current recommendations. So that will make our job easier. And as already introduced, these are panelists for the day. We have a surgical oncologist, Dr. Sachin Marda, a chest physician, Dr. Abhinav Guliani, a consultant molecular biologist from OnQuest Lab, Dr. Vinay Bhatia, Dr. Indu Bansal, who's a senior radiation oncologist, and Dr. Ashish Singh, who's a medical oncologist from CMC Vellore. So coming to the first case, this was a 73-year-old male who was hypertensive, diabetic, and had a history of left hip tuberculosis. He was coughing since 2 months, had an effort tolerance of only one flight, and used to use a walking stick because he had undergone a left hip replacement. He came to us with a CT scan. I hope these images are clearly visible. And as you can see on the CT, there were quite a lot of emphysematous changes, some pleural thickening, and you can see a spiculated mass in the right upper lobe. This is the mass. So, coming to the first question, a tissue diagnosis in this case, is it necessary? Dr. Sachin, would you like to comment?
Thank you, Sabita, and all the team. Yes, looking at the CT scan, as already you told, quite emphysematous changes and blebs are there, and there is a solid spiculated mass. Looks like quite suspicious for malignancy, but there are few guidelines which says that if it is a clinical and radiological picture is quite confirmative of cancer malignancy, one can avoid. But here I would like to do a CT guided biopsy because uh, probably since the patient is old case of tuberculosis, although it is not looking tuberculosis, but maybe sometimes it can harbor. And other more important is we have to do it very cautiously because as you know, there are emphysema and sometimes one may land up in a pneumo. So we should have a very good experience intervention radiologist who can do it. Although it is simple, it's quite peripherally situated lesion. But after biopsy, I would like to observe him in an emergency department and follow up with one more CT. And then if it's comfortable, I would allow him to go. Otherwise, I can keep under observation.
Excellent, Dr. Sachin. You have covered all the points that we would like to bring out with this CT scan. Dr. Abhinav Guliani, our chest physician, would you like to comment on this?
Yes, certainly. I would certainly agree with Dr. Sachin that this is a gentleman who has history of tuberculosis, and these lesions can sometimes mimic tuberculosis. But since there is a lot of emphysema, and given the age, you should certainly think of malignancy and try and rule it out with as safe with as much safety as you can. So a CT guided biopsy would be the safest. A bronchoscopy would be tough, since an endobronchial biopsy would increase the risk of causing a pneumothorax, and we might land up into trouble. There is also a thin rim of effusion. I would love to do an ultrasound and see if I can take the fluid and maybe get a diagnosis from that, or maybe go in for a PET scan first before the tissue diagnosis. That would also be certainly helpful.
Right. So he's an elderly gentleman with a lot of comorbidities and a lung which does not look very good. We did a CT guided biopsy and we got a diagnosis of adenocarcinoma. I would like to skip over this slide in the interest of time. And then we went ahead and did a metastatic workup. So I would just like to ask all the panelists, would in this kind of lesion, would you do only a PET CT, also add a MRI brain, or would you do no further imaging? Dr. Vinay Bhatia and Dr. Indu, would you like to take this question?
Yeah, so in this case, PET CT I would like to do, but it may still confuse because PET CT may give a false positive result if it's a tuberculosis or in lung diseases also, but PET definitely helps. It would help us in knowing other lymph nodal status or any other chances of malignancy can be ruled out. MRI brain, I would not be too keen to do as an initial first step or combine both PET-CT and MRI brain, because this looks like a very small lesion. And so MRI brain, I don't think is absolutely necessary. PET-CT would definitely help, but tissue diagnosis is a must.
Yeah, so we've already got a tissue diagnosis. Dr. Vinay Bhatia, would you like to add anything to this?
Basically, for if tissue diagnosis is already done and it turns out to be adenocarcinoma, so basic requirement for further therapeutic decision, we need to have EGFR mutation testing on the tissue sample, and the basic requirement for the basically for EGFR testing is that tumor content should be more as good as at least 50% of the viable tumor cells should be there in the tissue, so that a further diagnosis leading to the therapeutic decision can be taken.
Dr. Ashish Singh, our medical oncologist, is also here. Sir, would you agree that we would do a molecular testing on the biopsy specimen?
At the moment, currently, we have not even made a plan for him. So I wouldn't jump as right now. But maybe once I know the complete stage, I will rediscuss that and think about it. I saw in the CT scan, there was a lot of pleural thickening. So I was wondering, we don't have a radiologist, but are we sure there is no pleural spread there? That was one question. And also, he's an elderly emphysematous lung. So what is his fitness? The 6 minutes walk test and the pulmonary fitness assessment. That's something which I want to add here. Yeah.
Yes, we'll come to all that in another few seconds. So we did a PET-CT, and the PET-CT showed uptake only in the peripheral right upper lobe lesion. The lesion was 3 into 2.5 into 1.7 centimeters. There was no uptake in the pleural thickening, no uptake in the hilar or mediastinal lymph nodes, and there was no distant metastatic disease. So this was what his PET-CT looked like. And further evaluation, we also did an ultrasound guided tapping of the right pleural effusion, which turned out to be negative for malignancy. MRI brain was also done. So what the current guidelines say is that if you have a peripheral lesion 3 centimeters or less, you can avoid a MRI brain because the chance of brain metastasis is less than 4%. But this was just borderline 3 centimeters, and he was an elderly gentleman. So we didn't want to take any chances. We did a MRI brain. Also, regarding his cardiopulmonary fitness, we did a 2D echo, which showed an ejection fraction of 55%, but he had mild to moderate pulmonary hypertension, probably because of the previous COX and also the fibrosis and scarring. And his pulmonary function tests were not so great. The inspired volume in 1 minute was 43%, and the DLCO was 47%. So this is what the workup looked like. And now we had a lot of issues to be addressed. The first one was his age. He's 73 years old, diabetic as well as hypertensive, and he was walking with the aid of a walking stick, had undergone a previous hip surgery. He had history of COX. We had limitations in assessing his performance status. We could not do a 6-minute walk test. We could not do a treadmill test because he was walking with a walking aid. We could not do cardiopulmonary exercise testing. He had borderline pulmonary function and moderate pulmonary hypertension. So first, coming to Dr. Sachin, what would you think of this patient? Even though he is non-metastatic peripheral lung lesion, what would you think about optimizing his risk, or would you think of him as a surgical candidate?
Sabita, I don't think he's a surgical candidate, because even though the lesion is very early lesion, but as we all know, the thoracic surgery or any kind of intervention for him will be little risky. And I will also consult with my other pulmonologist colleague, anesthesia doctor, and take the consensus. But I don't think this patient will come up with the surgery, even though we convince, and even if it comes, it will be very, very high risk. So I think we have to discuss and then plan.
Excuse
Other
me,
modalities.
Dr. Sabita.
Yes.
Sorry to interrupt.
Yes.
Dr. Sunil Jaiswal has also joined here for the panel discussion.
Right. Welcome, Dr. Sunil.
Hi, good evening, ma'am.
Hi. Did you go through the previous slides? Did you get a chance?
Yes. I went to the previous slides. I'll agree with Dr. Sachin. He doesn't look like a surgical candidate. The other test that you can do is a assessment of his functions, O2 mismatch, VQ mismatch test we can do, but I don't think he's a surgical candidate as per with all the investigations provided.
So usually a perfusion mismatch, a ventilation perfusion scan is
Yes.
done in large masses where we think that the pulmonary function tests do not correlate with the functional status of the patient. So suppose you have a very good 6-minute walk test, but your pulmonary functions are borderline. So maybe only that much of the lung is functioning, and that has been reflected by the pulmonary function test. So usually patients who require a pneumonectomy or there is a mismatch, for small peripheral lesions, I don't think a ventilation perfusion scan would add much.
Yes.
Coming to Dr. Indu Bansal, what do you think of this patient? Peripheral lesion, 3 centimeters, and lot of comorbidities, limitations in assessing performance status.
So I think this patient is non-metastatic, has a peripheral lesion, not a good surgical candidate. This patient should definitely be considered for stereotactic body radiotherapy. So is a perfect, candidate for SABR because it's a peripheral lesion. So, and we would be able to take care of most of the parameters, the toxicity parameters that SABR can do. And the only limitation here is going to be the chest wall, which seems closer. But and if the lung functions, I would be little concerned about giving very high doses per fraction because of underlying lung disease. But he looks like a candidate for SABR definitely. And so this patient has already been proven to be an adenocarcinoma, 3-centimeter lesion. So no notes on PET. So SABR would definitely be considered, and I would like to have a discussion with my medical oncologist regarding any role of adjuvant chemotherapy also in this particular patient. But SABR is something which definitely should be.
Before we get in the medical oncologist here, I just would want to ask our pulmonologist, Dr. Avina Guliani, is there anything that can be optimized further in this patient?
Certainly, it can be. So the values of the pulmonary function test are only probably pre-bronchodilator. This person, because of his hip, we cannot assess his actual exercise limitation. So we should certainly get more values from the PFT or a complete PFT with reversibility seen post a bronchodilator. Optimize him with a good bronchodilator therapy and reassess him. Secondly, as rightly pointed out, VQ scanning can help in a bigger mass, but this is too small. But even then, if we have to consider or think of surgery in his case, doing a VQ scan won't harm. We can probably assess whether that portion of the lung is how much of ventilation and perfusion is being attributed to the right upper lobe. You would probably do well with a sleeve or a partial upper lobectomy, but yes, such patients with emphysema do not fare well. They would have a high leak post-op as well. So we'll have to explain the same to the patient as well. At 73, he might also reconsider going in for surgery. So his history of COX is also significant, which we should address. Maybe he should undergo a bronchoscopic lavage to rule out active COX, although the CT does not confer to that. Second, he should be optimized with a bronchodilator and reassessed. Sometimes, I would just add, not in this particular case, but we do get CT negative nodes, which we pick up on endobronchial ultrasound. We should certainly try and look for them whenever we have such a lesion, and CT negative nodes can be picked up by a screening EBUS prior to surgery, and we should think of doing that in most of our patients.
Right, thank you. So coming to the choice of treatment, first I would like to address the question of mediastinal staging that was brought up by Dr. Abhinav Guliani. So we usually tend to follow most of the surgeons here, and I would like to ask Dr. Sachin and Dr. Jaiswal if they agree with me, that we follow the European Society of Thoracic Surgeon guidelines, the ESTS guidelines, which say that if you have a peripheral mass 3 centimeter or less, you can forego invasive mediastinal staging, which includes endoscopic as well as mediastinoscopic techniques. And definitely in this patient, you should do a systematic mediastinal lymph node dissection when you're going ahead with surgery, but you can forego the staging if the PET is negative. Anyone would like to add anything to this? Dr. Sachin or Dr. Jaiswal?
Yeah, I agree, Sabita.
Okay. So
I'll agree with you also.
Thank you so much. So we'll go on to the next slide, the choice.
Can I make a comment?
Sure, please.
Yeah. One thing that we have seen is The
Yes.
scar carcinomas, post-tubercular carcinomas are very, very slow growing. And I entirely agree this is not a surgical candidate and we should consider other forms of treatment, especially with the comorbidities. Thank you.
Thank you, sir. So these are the treatment choices that we have in front of us. Surgery, whether a sublobar resection or a lobectomy, concurrent definitive chemoradiation, stereotactic body radiotherapy, only radiation, radiofrequency ablation, or systemic therapy only. First, I'll give the platform to the surgeons. Would you all think of doing a sublobar resection in this patient?
I think even any sort of surgery will be little risky for him considering all the parameters. And the other options which are there are little over treatment for him. So I think as Dr. Indu Bansal already nicely elaborated, I can hand over the case to her so that she can do stereotactic body radiation.
Yes, definitely. And even for a sublobar resection, a segmentectomy is preferred over a wedge resection. And the guidelines say that a segmentectomy should be limited to lesions which are T1, which is 2 centimeters or less. And this is already 3 centimeters.
Yes.
So, yes.
I'll agree with Dr. Sachin.
Okay, great, great. Thank you. So, this patient, in view of his age, comorbidities, and pulmonary changes, was not considered a good candidate for surgical resection. He was discussed in a multidisciplinary tumor board, and then he was planned for stereotactic body radiotherapy, and he received 60 gray and 5 fractions. So, any comments, Dr. Indu, or could we go ahead?
I think I agree with the plan.
Okay, great. So there were just a few more questions, some of which we have already touched upon. Is there any need for mediastinal staging? So Dr. Abhinav Guliani was of the opinion that we should do a screening endobronchial ultrasound. But Dr. Sachin and Dr. Sunil, would you think that there's a need for mediastinal staging? And also Dr. Indu, would you like a mediastinal staging in a patient who is already planned for stereotactic body radiotherapy?
So in this particular patient, I don't think there is a need for mediastinal staging because it's a peripheral tumor, just 3 centimeters. So, and there is nothing on PET. CT scan also is not showing any suspicion of any node. So I don't think for this particular patient, mediastinal staging would be of any help. But if there was any suspicion of any node on PET CT or something, then I would have definitely liked to do a EBUS before planning for SBRT, if it would be done, but not in this.
I would like to make a comment.
Yes, please.
This lesion is a less than 3 centimeter lesion, but you see there is a localized effusion. So it may turn out to be at least a T2 lesion if the visceral pleura is involved. So I would strongly recommend to do a invasive mediastinal staging, at least in EBUS.
Okay.
And I would also like to add something, as Dr. Santosham had pointed out, that this could be a scar carcinoma. We should at least undergo a lavage so that a coexistent tuberculosis can be picked up if it is there. And that can be, we ruled out malignancy on the pleural fluid analysis, but we did not know whether it could be tubercular or not, since an active TB will have an effusion. So for that purpose, I would recommend an EBUS, not for staging for the cancer maybe, but we should sort of try and rule out active ongoing tuberculosis as well.
Great, that's a good point.
This, if I remember correctly, this patient had not a pulmonary tuberculosis, he had an extra pulmonary tuberculosis. So can we label it as a scar carcinoma?
The way his CT picture is looking, it looks like he had pulmonary also, even though
he probably had pulmonary which had spread later on to the hip.
Yes.
He did not get hip tuberculosis as a primary tuberculosis. This was probably a focus which had spread, and the pulmonary lesion would have healed up on its own without him knowing it.
And one more question for Dr. Vinay Bhatia. So what do you think is the role of molecular testing in this case? First, please answer this question and then we'll come to the second part.
Basically, in this particular scenario, molecular testing is not required as far as my understanding goes.
Yeah, anyone else in the panel would like to do molecular testing? This patient has already undergone stereotactic body radiotherapy and we have a biopsy which says adenocarcinoma. So any role of molecular testing? I don't think anyone has an opinion. Would anyone like to give this patient any kind of adjuvant therapy, either systemic therapy or targeted therapy after SABR?
Yes, so Dr.
Dr.
Ashish here. Yeah, so this is an elderly gentleman. What it looks like is a stage 1, 3 centimeter, and with whatever best imaging we have confirmed that it has not spread to the mediastinal node. So in my mind, his risk of relapse in the next 3 to 5 years is not going to be more than 20-30%. So
Right.
when I'm going to have more than 70% of these guys being disease free without any treatment, and so if the risk is low, I think whatever we do now is not going to bring that the risk even further lower down. And even for chemotherapy, definitely, even if he would have had surgery, I would not have offered him chemotherapy. Yeah. Regarding adjuvant targeted therapy, I mean, the ADAURA trial discussed did not include these kind of patients. So we do not even know about the safety of osimertinib post radiation. However, if all the other panelists were saying they were keen to do mediastinal staging, if some of the mediastinal nodes were positive and this was stage 3, I would have actually argued with the radiation oncologist saying osimertinib would have a higher response rates and higher duration of control than the SABR what we are all advocating. And anyway, if in a node positive patients, we wouldn't have gone for SABR anyway for him.
Right, right.
Yeah.
Right. So a lot of nuances to the treatment, even in a simple peripheral mass. And there are so many opinions and so many things that we need to take into consideration. Very well brought out by all our panelists, and thank you so much. So this patient did not receive any adjuvant treatment after the SABR, and he was well controlled at 1 year follow-up. We'll go on to the next case. And again, an elderly patient, a 76-year-old lady, non-smoker, hypertensive and diabetic, who had cough and anorexia for 6 weeks, and she had an effort tolerance of 1 flight only. So she underwent a CT thorax, and here we see a right lower lobe mass, not so peripheral, coming on to the central portion, and there's also a node which you see along the interlobar pulmonary artery. And this was the mass which was localized to the right lower lobe, not abutting the chest wall, not abutting the fissure. And the biopsy was adenocarcinoma. We also did a bronchoscopy, which was normal. There was nothing endobronchially. And this was the PET CT. So on the PET CT, there was this mass, but no significant hilar or mediastinal nodes, 3.5 centimeter right lower lobe lesion, MRI brain normal, but she had a decent pulmonary function test, FEV1 of 72% and DLC of 63.3, and the 2D echo was also normal. So even though she was 76 years old, she seems to be more fit than our first patient, and better lung functions. So now in this case, I would like to ask the panelists, do you think mediastinal staging is required? And which modality would you use to do this mediastinal staging? We would start with Dr. Abhinav Guliani, our chest physician. What do you think? Which modality would we use?
So certainly mediastinal staging is required. In today's day, a combined procedure of EBUS plus EUSB, which we can do with the bronchoscope itself, has practically replaced invasive mediastinoscopy in terms of staging. We can look and sample most nodes. We can even take tissue for our cell blocks for mutation analysis. Also, at our center, we have started doing an intranodal forceps biopsy, wherein we can put in a forceps through the EBUS channel and take a biopsy from the node itself. So I certainly recommend that for this patient, EBUS and EUS both combined should be done as a staging modality, since we had highlighted that there is an interlobar node involved as well. So we should actively look.
Dr. Sachin, Dr. Sunil, any comments?
Yes, ma'am. For the center that I am working at, we do not have EBUS and US at our facility. So for my preference, I'll have to do a mediastinoscopy. I also do not have a distentable mediastinoscope. So most probably I'll be doing it via VATS and stage that out. For centers, those who have EBUS and US, I will prefer this over a mediastinoscopy.
Thank you so much. That's a very important point that you have brought out. Centers which do not all centers would have endobronchial techniques to invasively stage the mediastinum. And in those cases, the mediastinal staging really depends on the surgical oncologist or the thoracic surgeon. Dr. Sachin, what about you?
Yeah, at our center, we have all the infrastructure is available. So I think, as Dr. Abhinav already mentioned, endobronchial ultrasound, maybe plus minus EUS, but EBS is mandatory.
Just for the sake of the trainees and residents in the audience, can you please enumerate the stations which can be accessed by endobronchial ultrasound?
Can I have a go at it?
Yeah, please.
So by endobronchial ultrasound, we are looking at stations which are right next to the major airway. So which start with the 2R, 4R, 4L, which is the paratracheal location. We go on to the subcarinal of the station 7. We go on to the station 10, which is on both the sides, 10R and 10L, which is alongside the hyla. And then we can go on to the 11 and 12, which is the interlobar station. The interlobar station is better accessed on the right rather than the left. So this is through the endobronchial ultrasound. If you put that scope through the esophagus, it is called EUSB, wherein you can also access the paraesophageal nodes, which is station 8.
Right. I would also like to ask Dr. Sachin, would mediastinoscopy add anything over the endobronchial ultrasound?
I don't think, but sometimes when the CT and PET CT shows the nodes in the mediastinum, and even though they doesn't look like, but still 15% of cases may be something like metastatic deposits or nodes positive would be there. So it can convert the stage. So probably there is very limited role, but as practically endoscopic ultrasound and EBUS has replaced, so very minimum role of mediastinoscopy.
If you have a negative EBUS and a EUS, would you still do a mediastinoscopy?
I'll add on to that. If you have a very high clinical suspicion that you may harbor a positive node, for example, if the node is more than 3 centimeter or somewhere around that, and your EBUS and US techniques have come out with a negative report, in those cases, I'll still prefer to go in and do a mediastinoscopy.
Okay, so we did a endobronchial ultrasound guided FNA, and all the stations, station 7 subcarinal, right paratracheal, left paratracheal, upper and lower, all were negative. So this was the stage of the patient. And further management, I would like to ask everyone, would you still do a mediastinoscopy? I think already been answered. Straight away go ahead with surgery, that is a lobectomy, surgery with mediastinal lymph node sampling, surgery with systematic mediastinal lymphadenectomy, or consider this patient for non-surgical management in view of her age, which is 76 years. So Dr. Abhinav, what would you recommend?
So I would certainly recommend surgery to her. In case she refuses, that's a separate story. But my recommendation to her would be surgery with systematic mediastinal lymphadenectomy. So that
Dr.
would be
Indu?
I recommend.
Thank you. Yeah, Dr. Indu?
So surgery, I would also first recommend surgery, but also give her an option that if she is technically unfit for surgery due to any reasons, medically inoperable or patient not willing, then SABR is an option. But first option would be surgery definitely for her, because it would give us an additional advantage of mediastinal lymph node staging, which we won't be able to do with SABR.
What about you, Dr. Ashish Singh? I'm just asking the non-surgeons first.
Yeah, I mean, I think surgery is the best local treatment because it gives you the best mediastinal staging, and that's paramount in deciding the course for this patient.
So just two quick questions to the surgeons: mediastinal lymph node sampling or mediastinal lymphadenectomy?
Yeah, please go ahead.
Now you can go ahead.
I think a surgery with systematic mediastinal lymphadenectomy would be the proper choice, even though the overall survival and disease-free survival have not made any difference. But since it is open and it is the one who has a high volume center, it doesn't take much time. Maybe we can finish in next 15-20 minutes and without much comorbidities. And we should have, for the sake of residents, at least minimum 6 nodes should be there. 3 from hilar and 3 from the mediastinum, so that our pathologists can exactly stage and can prognosticate, and then if required we can do other molecular samples if the specimen is inadequate. So my say would be surgery with systematic mediastinal lymphadenectomy.
Any other comments?
I am not a big fan of mediastinal lymph node sampling. The message to the house should be that we should avoid doing that. Standard of care is doing a systematic mediastinal lymphadenectomy. As far as we can avoid, try avoiding doing a sampling.
Correct. I would agree with you, because even though the biggest trial showed that sampling is equivalent to systematic mediastinal lymphadenectomy, the meta-analysis of the 4 randomized control trial shows a favorable prognosis with a mediastinal lymphadenectomy. So as per our institutional policy, even if the EBUS is negative, we will do a mediastinoscopy. We did a video-assisted mediastinoscopy, sent all the stations, and they were all negative. Then the patient underwent a right lower lobectomy with a VATS approach with systematic mediastinal lymphadenectomy under the same anesthesia. And this was her histopathology. So just one more question to the surgeons. Which approach would you prefer in this case, open or VATS?
VATS preferable.
Yes.
Yeah, so the recent NCCN guidelines in 2021 have also said that VATS or any other minimally invasive approach, including robotic, is preferable over open for stage 1 and stage 2 selected patients, because it offers the benefits of less pain, lower hospital stay, lower ICU stay, and better recovery. Coming to the histopathology, it was turned out to be a 4-centimeter mass, adenocarcinoma, all margins were free. TTF1 positive, EGFR was evaluated in this patient positive. 1 hilar lymph node was positive for metastasis, and 10 mediastinal lymph nodes all negative. So looking at this, Dr. Vinay Bhatia, what would you say? Can you hear us? Dr. Ashish Singh, would you like to take this question?
Yes, and so this lady has a node positive disease, even though she's only 1 out of 2 hilar node and other mediastinal nodes are negative. However, she does have a significant risk of relapse, so adjuvant therapy should be advised. The surgery is quite good, so there is no role for any adjuvant radiotherapy here. If you go by the latest meta-analysis, we would advise chemotherapy first for her. Based on her creatinine clearance, I would want to give her a cisplatin doublet. So with pemetrexed combinations, PEM is usually well tolerated. Up to 4 cycles is what we advise. And then we discuss, because she's got an EGFR mutation positive, and now we have data from the ADAURA trial. And if you look at the control arm, where the patients did not get the TKI, the risk of relapse was significant, significantly high in node positive patients. And we do know that Osimertinib will reduce her risk, will at least delay her recurrence. Now, whether this is only delaying recurrence or adding to cure, we are eagerly awaiting the overall survival results. But as of now, with the information we have today, compared to all the other TKIs, Osimertinib seems to be have the magnitude of benefit seems to be highest. But the point I want to put across is that this shouldn't be done without proper mediastinal staging, good surgery, chemotherapy, and then we can discuss.
So I would just like to play the devil's advocate here. The Osimertinib study, the ADAURA trial, even though it has shown a very impressive hazard ratio of 0.17, something we have not seen very recently in lung cancer studies, this drug was given for 3 whole years. What about the compliance, the patient compliance, and also what about the cost, especially in our setting? How would you
Sure, so if you look at if you look at the compliance part of it, I mean, the only 2 reasons why our patients would discontinue a drug would be if it's making them feel worse, that is giving it toxicity or reducing their quality of life. Now, agree that the toxicity was shown by Dr. Sandeep Goyal in his talk. Most of them were mild, even though rarely we have seen like mucositis and diarrhea. But compared to erlotinib, gefitinib, this is a much better tolerated drug. And so I don't expect more than 5-10% of patients. Most of the other patients would be able to continue. Now, other important aspect is cost. Yes, of course. So because the cost at the moment Even though it's cheaper in India as compared to other countries, still it's most of our patients are unable to stay on the therapy, even if they may be able to start. So this is something which has to be discussed right on day one, that we are going to give it to you for 3 years, and it may delay recurrence. Also, if you don't do it right now, what would we do when you relapse? We'll be using the same drug, because we know Osimertinib is better than the other TKIs in terms of overall survival in advanced disease. So more or less, the discussion is going to be taking it now versus taking it at relapse.
So any of the surgeons, if the patient comes back to you and says, you are the doctor who operated on me, like most of the Indian patients do, and they say, okay, what do you think I should do? What would you counsel the patient?
I think, yes, with the nice results which are shown by the ADAURA trial, I think at least we will have a multidisciplinary discussion. We'll involve medical oncologist, we'll involve the pathologist and molecular biologist, and then give the option to the patient. But I think we can convince to a certain extent to few patients to go ahead with the new drugs.
I'll also try to convince her for the treatment.
Yeah, so what we are doing is that patients who are actually reimbursable, or patients who would not suffer the financial toxicity of this drug, because there is no study which says it can be taken for 6 months or 1 year, like we have in trastuzumab, that a shorter interval is as equal as to a longer interval. So 3 years is reasonably a long time for any patient to be on a drug, and only the patients who understand this, I think, should be counseled regarding and who can bear the financial toxicity of the drug. I don't think Dr. Vinay Bhatia is here. I would like her to chip in at this time. Anyway, I would just like to ask the organizers, do we have time for the third case, or are we done? Because I realize we've overshot the time by half an hour for the entire webinar.
Hello, can you hear me?
Yes, I can hear you.
Yeah, basically for early lung cancer sample patients, molecular tests recommended. Basically, EGFR and ALK are the minimal biomarkers which needs to be tested. As far as the technology and platform recommendation is concerned, for early lung cancer also, if we have a broader molecular profiling system which may be used simultaneously for multiple markers, that is always wonderful, because say for example NGS is a massively parallel sequencing which is a broad molecular profiling system that can detect panels of mutations. And even moreover, NCCN guidelines also recommend EGFR, ALK rearrangement, ROS1, BRAF, and anti-RK mutation testing also. So if we can use, if the costing is not an issue, then NGS is always a better platform which will give us an overall information about the biomarker based therapy. So NGS is always better as far as technology wise is concerned, because if tissue is also an issue in most of the cases, and the same sample cannot be reused because sample becomes a limiting factor.
Right. Okay, thank you so much. So I think I'll end the presentation here, because we are really running, we have overshot the time, and I'm not being able to stop sharing. I've paused my sharing. Can the organizer please help?
Yes, ma'am. Shall I stop sharing?
Yes, please. Yeah. Thank you to all the panelists for a wonderful panel. And I think we covered some really important points. And thank you for being so cooperative and forthcoming with your views.
Thank you, Dr. Sabita.
Thank you. Thank you, ma'am.
Thank you, Dr. Sabita, for leading the panel discussion, and thank you to all our panelists who has given us an amazing information, and the attendees who have joined us has given us an amazing feedback. That was really informative session. So with this, we are coming up to the end of the webinar. So before we wind up, I would like to once again thank each and everyone who has joined us. Firstly, I would like to thank AstraZeneca and OncoQuest Laboratories who have brought up this topic on how to detect and the treatment for early lung cancer, which was an amazing and very informative topic for the current scenario. And next, I would like to thank our chairperson, Dr. Rajan Santosham, and our speakers for the day who had joined us, Dr. Vinay Bhatia, Dr. Shoaib Zaidi, Dr. Sandeep Goyale, and our amazing panelist for the day, Dr. Sachin Madra, Dr. Indu Bansal Agarwal, Dr. Sabita Jivnani, Dr. Abhinav Gilani, Dr. Ashish Singh, and Dr. Sunil Jaiswal. For all who have joined us, irrespective of your busy schedule, thank you so much to all of you who have joined us. And any message that you would like to convey to our audience?
Zizil, I want to say something.
Yeah, sure.
Thank you very much, especially because of this COVID scenario. As somebody was saying in our discussion, that people are doing so many CT scans for, to just rule out the COVID. And believe me, and all the doctors who are practicing in their day-to-day life, lung cancer, early lung cancer, we are picking it. In last 12 months.
I was the person who said that. I was the person.
Yes, Dr. Rajan. Sorry, sir. But it was very nice that you have brought up the topic, and I think we'll able to give justice to all our patients with these wonderful sharings and thoughts. Thank you very much.
Thank you so much, Dr. Sachin. And before we wind up, I would like to give a small announcement about the two upcoming international conferences organized by the International Association of Oncology. We have the third Into Oncology Summit coming up in the month of September, which will be happened in India, in the state Bhubaneswar. Interested participants, we have shared the link in the chat box. And also we'll be conducting the Asia Pacific Cancer Congress in the month of December at Maldives. And we have shared the link in the chat box. I would like to inform you that the Asia Pacific Cancer Congress is exclusively booked at an island for all the oncologists and delegates attending from across the globe to assure the safety protocols for COVID-19. So that will be a great platform to enjoy your vacation and share your expertise with the other oncologists participating from across the globe. So if you're interested, do check out the website, and the registrations are open. So thank you so much once again to all our doctors and experts who have joined us. And thank you once again to AstraZeneca and OncoQuest, and good evening and have a nice day to one and all.
Thank you. Thank you so much.
Thank you.
Thank you.
Thank you.
Thank you.
I think we had a good meeting, and the discussions were good. The speakers were good. And I congratulate Sabita for doing the discussion very well. I enjoyed it. Thank you. Good night.
Thank you, sir. Thank you so much. Thank you.
Thank you, sir.
Good night, sir.